Welcome everyone to the third e-seminar on anemia management in chronic kidney disease patients. I'm John Barratt. I'm a nephrologist from the University of Leicester here in the UK, and I've chaired the previous two sessions as well, which have been really great discussions around what's happening in anemia of CKD and what might be happening in the future in terms of new therapies and new approaches. And it's a real pleasure to be joined by two experts today. Evi Nagler from Belgium and Sokratis Stoumpos from the UK. And I'm just going to ask Evi to introduce herself and then Sokratis. So, Evi, would you like to tell everyone a little bit about yourself?
Gladly. Hi, I'm Evi Nagler. I am a practicing nephrologist here in Belgium in Ghent University. My daytime job is transplant nephrology. So I'm not here particularly as a content expert on anemia. I'm part of the KDIGO guideline developments panel on the new anemia guidelines in CKD. But I'm primarily there for my expertise or experience, at least in evidence-based medicine and guideline development methodology. I've been part of ERBP for a long time as one of their guideline development methodologists. And so, yeah, I was brought in, I think, for this seminar partly because of that background as well. And so I think kind of any contribution should be seen from that vantage point.
Thanks very much. And I think that's really important because the KDIGO are reviewing the anemia guidelines at the moment, aren't they? While you can't comment on those in particular, you understand what they're looking at, why they're looking, and how they're reviewing the data.
Absolutely. Yeah. They're expected to come out somewhere next year, 2024. We're on a tight schedule for that. And it's been a very exciting process so far, with lots of interesting views coming together from experts who have expertise in basic science. We've got the clinical experts, and we've got more guideline development methodologists on board as well. And that brings together a nice variety of views on the topic, certainly.
Great, thank you. And Sokratis, would you like to tell the audience a little bit about yourself?
Hi there, I'm Sokratis. I'm a nephrologist in Glasgow, Scotland, and I'm here to represent ERBP today. I'm an advisory group member in ERBP. Again, my research is mostly related to cardiorenal failure, but I have been heavily involved over the last couple of years with anemia, leading a kind of a consensus paper via ERBP, which is hopefully going to be out soon. That's why I'm here today.
Great. Well, look, it's great to have you both. So, as what we decided to do for this particular seminar, as I posed 4 questions, if we could just go to the next slide, really as a discussion point, what I'd really like of the participants to think about these questions as we're discussing and come up with their own questions for the panel, because I think these are areas which we don't know the answers to at the moment, which is why I've asked them, and there'll be good discussion points. But please, if you are watching live, then please do ask questions in the chat, in the Q&A function. We've already had some questions come through, and if we get time, we'll go to those at the end. But you can see the questions in front of you. First of all, I wanted to really bring up, where do we think these new agents, the HIF stabilizers, will fit into anemia guidelines going forwards in the different types of patients with CKD that we look after? Something that I'm particularly interested is, can we actually ever safely achieve normal hemoglobin in our patients with anemia of CKD? Is that desirable? Is that possible? And if it is something we want to achieve, how on earth are we going to design a trial to be able to test that, bearing in mind the data we know that has come about with erythropoietin stimulating agents? And then thinking about where the next innovation will be in the treatment of anemia of CKD and what might be those new therapeutic targets. And finally, and it's a question that comes up at every meeting I go to, particularly with the new agents, is how do we approach managing anemia of CKD in patients with active malignancy? And that's particularly important because we're looking after an older population. And certainly in my practice, I'm seeing lots of patients who have CKD and malignancy of various types, of various stages, and on various treatments. And how do we handle that in our clinical practice? So the way this is going to work, each of Evi and Sokratis are going to present their answers to the questions that I've posed, and then we'll have an open discussion. And please pitch in with questions in the Q&A if you've got questions around this area as well. So Evi, first of all, if we go to the first question, would you be able to share your screen?
So to start with my disclosure of interest, so I've told you I'm a member of the guideline panel in KDIGO. I don't have any other interests. And so whereas I'm not a particularly content expert, I think one of the advantages is that I'm a fairly disinterested advocate here. I have no correlation with any of the companies, and I don't particularly deal with anemia of CKD a lot in my clinical practice, given that I mostly spend my time with transplant patients. So position of HIF-PHI in anemia management. Well, I think my idea on the matter would be that, that any guideline could certainly discuss its place in depth, but that at this point in time, I feel based on the evidence that we see that there's a very restricted scope to advocate their use, especially over ESA as a primary treatment. And I think for a more detailed perspective, I think we should revisit the fundamental question of why are we addressing anemia? What is it that we're trying to achieve by treating anemia? Which outcomes do we hope to improve? And do these outcomes actually matter to patients? And at least if you ask people who live with CKD, then what triggers them most, so what they find most important is fatigue. It's live participation, it's cardiovascular disease, it's mortality, and for those on hemodialysis, it's a functioning vascular access as well. And that's supported by the SON Consortium, which aims to standardize outcome measures for studies evaluating treatments in these patient groups. Now, the crux of the matter here is that no evidence to date exists that HIF-PHIs offer better quality of life than ESAs. And there's no proof to suggest that they're any better, that they're any safer. And in fact, the limited data that we do have available seems to suggest the contrary, be it of a very uncertain quality. And so the best evidence to date comes from a Cochrane review, which was published in 2022, which assessed HIF-PHIs against placebo and ESA through the lens of 51 randomized trials, including over 30,000 participants. And then when juxtaposed against ESA, the impact of HIF stabilizer treatment on cardiovascular death was definitely ambiguous, showing a point estimate of 3 more deaths per 1,000 participants, with a confidence interval spanning 3 fewer to 6 more. So definitely a point estimate not in favor for HIF-PHI at that point. And the therapy's influence on any of the other outcomes, non-fatal myocardial infarction, non-fatal stroke, hospital admission due to heart failure, peripheral arterial incidents, sustainability of the dialysis vascular access, access interventions, cancer recurrence, infections, etc., all remain inconclusive. And I think importantly, if we look at fatigue, there again, effects were very uncertain. None of the included studies looked at or reported live participations. Adverse events were rarely and inconsistently reported. And so there's no question that these compounds do increase hemoglobin. There's no difference in reaching and attaining target hemoglobin. And so their effectiveness when it comes to mitigating anemia is not under debate. But the question is, does it do anything over that in comparison with ESA? Now, we can kind of incorporate patient preference into that conversation. And I don't have any particularly nice visual to show you that. But despite a higher number of deaths observed with HIF-PHIs, there's no solid evidence that there isn't heightened risk for them either. And so HIF-PHIs might find a position in treatment plans where patients favor an oral treatment over a subcutaneous one. And interestingly, in the beginning of 2023, a study was published using a discrete choice experiment, which kind of suggested that patients were open to a 5% escalation in their risk of a major cardiovascular event if it meant shifting from a bi-weekly at-home subcutaneous injection to a thrice a week oral pill. Now, again, I think that study wasn't without its flaws, and there was notably a high risk of response bias. And I think what's more crucial is that it was entirely funded by Astellas. And so, some might call me a skeptic, but I think I'd place more trust if such findings were produced by an independent entity. And that's especially true given the significant emphasis placed on cardiovascular incidents in the overarching focus groups that informed the SONG's standardized outcomes. And I think it's plausible to think that there might be a place for HIF-PHIs when dealing with unexplained or untreatable instances of ESA hyperresponsiveness. But that perspective is really based on small and uncontrolled studies. And these studies suggest that some patients who are unresponsive to ESA experience an increase in hemoglobin when they are switched to HIF-PHIs, but the dosages administered in each of these studies are consistently higher than those that are used in the efficacy trials. And so that really calls into question any safety assumptions derived from such findings. And so given this, I don't at this point believe there's enough conclusive evidence to recommend this treatment outside of a clinical trial environment. And personally, my feeling is that the situations like ESA allergies and ESA related purulent salaplasia that might be among the few instances where opting for HIF-PHIs could be justifiable.
Thanks very much. That's very provoking. And to Sokratis, would you like to present your view on that question? If you could stop sharing, and then we can move to the Sokratis slides.
Okay, yeah.
Oh, sorry, I'm trying to unshare. Ali. Oh, yeah.
Yeah, okay. So, can you see my slides, please? Yeah. Okay, that's fine. So, so these are my disclosures. Yes, I'm a member of the ERBP. I have not personally been involved in any of the IFPH inhibitors trials. Before I try to address directly the question that Prof. Barratt has asked, I just wanted to show you this very interesting slide. So this was published a couple of months ago following an anemia controversies conference, which was held in December 2021 by KDIGO. Following that meeting, they came out with this table, which kind of demonstrates potential advantages and disadvantages of different ages used for anemia. So with regards to HIF PIH inhibitors, I have kind of emphasized the ones that I'm going to focus more. Obviously, they offer a more convenient mode of administration. This may have benefits with regards to a burden of hospital visits, for example. Patients may prefer that with regards to not using injectable erythropoietin. And also may have implications with regards to equity and to accessibility to more patients. Definitely, it can facilitate anemia management in patients with non-dialysis dependent CKD who don't routinely attend hospital for hemodialysis, and they don't and they can kind of treat the anemia with tablets. The next point is potentially they can improve iron utilization for erythropoiesis, particularly for oral iron. A consistent finding in the trials was that levels of iron transferrin and total iron binding capacity were increased with these agents, and at the same time, levels of ferritin and hepcidin were decreased, which is in keeping with better iron utilization. Though I have to say here that it was not a consistent finding within all the trials, and these patients still require iron to maintain adequate iron stores before they start on treatment. There's also a point here saying that this can be more effective in patients with chronic inflammatory states with CRP over 5. This is yet to be proven. Patients with a proper inflammatory response with CRP up to 100 were excluded from the trials. And the ones included with CRP of over 5 were the ones that had CRP up to 10 or 15, and only 15 or 20% of them were included in the study. So again, this is a point that needs to be proven in clinical practice. And then with regards to disadvantages, potential adherence monitoring, which is the case with all oral tablets. I don't think it's a major issue with these new agents. It's the same as with all the usual tablets. Polypharmacy and drug-drug interactions, again, not a major issue. Obviously, less clinical experience. There is more data accumulating at the moment, and post-marketing data are going to be very, very important, just because all data are coming from trials so far. And then these are potential risks with the new agents, the risk of enhancing tumor growth. They interfere with multiple signaling pathways. They have pleiotropic effects. They can affect cell differentiation and cell growth. And there is a risk potential in patients with recent cancer. I think we're going to cover that in later today. Potential risk of worsening retinopathy. Again, they have a neovascularization effect by promoting vascular endothelial growth factor, and that may be quite important in patients with ocular pathologies such as diabetic retinopathy. And finally, there's a potential risk of cyst growth in polycystic kidney disease. This was shown in a couple of animal studies, but these patients have not been excluded from all HAF stabilizers trials so far, and there's no signal to suggest that this happens in humans. So I just wanted to demonstrate some general points with regards to the HIF inhibitors. Moving to specific recommendation, I think for patients with non-dialysis CKD, it's definitely a good alternative. It's an oral agent. People don't need to attend hospital. They don't need to inject with erythropoietin. There's no storage requirements. As Evi mentioned, there was a signal of increased MACE risk, and this was more prominent in patients with non-dialysis CKD as in general in trials. And this is something we should take into account, especially in patients that had a recent cardiovascular event. With regards to dialysis in general, again, patients with peritoneal dialysis, there are trials that have shown similar efficacy in patients both on hemodialysis and peritoneal dialysis. So this group of patients is definitely a very good one to target. The non-inferiority margins of MACE was met in both peritoneal and hemodialysis patients, and this is quite reassuring. So I think the peritoneal population is one that these agents could potentially be beneficial. The same with home hemodialysis patients. Again, they don't attend the hospitals, and they probably don't have the facilities to inject the darbepoetin at home. With regards to hospital hemodialysis, yes, it's again, as Evi again mentioned, sometimes it's down to patient preference. They may prefer an oral agent than an injection. At the same time, there is growing evidence suggesting that patients with erythropoietin hyporesponsiveness, patients with inflammatory states may respond better to HAF inhibitors. And again, the evidence is not great there to justify a recommendation on that. And finally, I think there are patients that may be intolerable of erythropoietin, that these patients, these agents may be eligible. With regards to transplantation, I think things that are much more complicated. Via the pleiotropic effects, they affect the immune system. They have various kind of signaling pathways that they alter, and we don't know what is happening in this group of patients. They have not been included in the trials. And apart from the potential risk of cancer, there may be a risk of rejection as well with the interaction of these agents with the immune system. I think that's where we are just now, and that's my perspective and my read of the literature of the trial so far.
Thanks very much, both of you. So if you could stop sharing now, Sokratis. I mean, I think I think we're all agreed that these agents increase hemoglobin, and they can increase hemoglobin to target, and they can maintain hemoglobin within the target range. I think, as both of you have alluded to, the data on the aspiration had been, hadn't it, that we had a drug that was more safer from a cardiovascular standpoint than current standard of care, and we don't have that data. At best, we have an equivalence or non-inferiority, should I say. So in terms of, well, I'll tell you what my approach is. My approach is that one HIF stabilizer is approved in the UK and in Europe for use in non-dialysis dependent, well, in all patients really, but we really focus on non-dialysis dependent patients. And I will offer the patient the choice in an informed manner by explaining the benefits and the risks associated with that on an equal footing to current standard of care, which is erythropoietin. So that's my starting point in terms of how I do it. And that's not to say that it's the right way. So I'm just going to Evi. So for me, I'm offering my patients the choice based on and making sure they understand the benefits and the drawbacks of both approaches. Do you think would you be comfortable with that, or do you think that you wouldn't be comfortable in your practice doing that at the moment with the level of evidence?
I think my response to that would depend on what the real costs of the product would be. I don't think we have very good views on that at the moment. And pricing and real societal cost would be a major factor influencing how I would recommend or offer these treatments within the healthcare system that we have, for example, in Belgium. I am a bit worried about the cardiovascular risk, in the sense that, as you said, the molecule was developed predominantly with the aspiration of offering something that was going to be safer than ESA. And at the moment, we don't have the evidence for that. And the signal that is there suggests the contrary. It is not good evidence. And certainly that it's not enough of a signal to indicate an increased risk. But with that in mind, I would like to see more evidence ruling out that the risk might in fact be increased for those new compounds.
You're erring on the side of caution here.
Yes.
Better the devil you
But I think cost is definitely something that is high on my mind when I offer patients the choice. The impact of that on the sustainability of the healthcare system as we know it is, for me personally, that becomes a very important factor in that kind of decision making.
And that's quite right. And I think the other thing, of course, is that the price will be different in different countries in Europe and in the UK, because we all have different systems. And of course, it's always confidential and we don't really know what anyone else is paying. And Sokratis, just to finish this conversation off, what is your approach in practice to using HIV stabilizers in your patients?
Yes, just to build up on what Evi just suggested with regards to the cardiovascular risk, I think first of all, not all trials have shown that they have increased cardiovascular risk. The non-inferiority margin was actually met in most of the trials, and there are many speculations with regards to how these trials were designed, with regards to intention to treat versus on treatment populations, with regards to geographical area, inclusion criteria, and various other factors. So I don't think we should discard with, based just on the cardiovascular kind of outcomes. Yes, with regards to our practice, obviously, yes, patient preferences is very important, and I would definitely give the options to the patients. However, we have kind of developed the internal guidelines. So we have specific populations that we should offer them, at least for now. And that's a consensus within our unit. With regards to finances, we have kind of done like an informal analysis in our unit, and especially for the lower doses of the HIV stabilizers, they work about the same as the darbepoetin, though that may include, kind of expenses for, how you're going to dispense the medication and things. I think practices vary depending on the setting, but patient preferences is definitely going to be a major contributor in the months or years coming with the new agents.
Thanks. So lots to think about. So we'll move on to an easier question. Perhaps not. So Sokratis, you can answer this one first, but do you ever think we're going to be able to safely normalize hemoglobin in patients with CKD? Because we know there are patients with normal hemoglobins who don't run into problems, particularly perhaps those with PKD, and that a normal hemoglobin achieved physiologically does not seem to be a negative indicator in terms of cardiovascular risk and morbidity. So do you think we're going to be able to get there pharmacologically?
Okay, I think again, I'll share my slides. I have a slide there in with regards to this question. So can I see that? You can see that, yeah?
Yeah.
Okay, so again, before I answer this question, I just wanted to show you some kind of data from landmark trials in the field. So on the left-hand side, it's the normal hematocrit cardiac trial. So this was done back in 1990s, looking at the effects of normal versus low hematocrit in patients with dialysis with cardiac disease and apoetin beta. So patients were randomized to normal hematocrit. As I said, it's hemodialysis patients of 42% versus low hematocrit group with a hematocrit of 30%. The risk ratio was 1.3. Didn't exactly meet the pre-specified criteria for high risk. However, in the context of the events, this trial was stopped prematurely because it was thought that high hematocrit is associated with worsening probability of death or myocardial infarction. And this was mostly led by the outcome of death. They had approximately 30 more deaths in the group of high hematocrit compared with the low. And I think the numbers were something like 180 versus 150 deaths. In non-dialysis patients, the CORE trial showed kind of similar outcomes when we try to normalize hemoglobin in patients with CKD. They've used a different outcome. It was a composite of death, MI, hospitalization with heart failure and stroke. And the randomized patients in the normal hemoglobin of 13.5 versus hemoglobin of 11.3. And they found a significantly higher risk of the composite cardiovascular outcome in patients with normal hemoglobin. This was subsequently replicated in other trials in non-CKD, including the TREAT trial, including the CREATE trial, which again did not show any cardiovascular benefit with regards to higher versus lower hemoglobin levels. There are there are suggestions. There are kind of suggestions that this was mostly related to the higher darbepoetin doses in patients that were resistant to EPO and requiring higher doses of ESAs to achieve the target hemoglobin. These were the ones that had the worst outcomes, whilst patients that achieved hemoglobin of around 11, 12 with lower ESA doses, they had better outcomes. So there is an argument there that this may be related mostly to the ESA dose rather than the actual hemoglobin rise. But the way it stands just now is that in this patient, we should not normalize hemoglobin. We were expecting that HIF stabilizers are going to show us better outcomes with regards to cardiovascular events, but again, this has not been proven so far. And at this point, I just wanted to say that we probably need to reconsider what we consider normal versus abnormal in this patient. So what is normal for the non-CKD population may not be normal for the CKD. And this has been shown in previous trials when we're trying to correct other parameters. In the EVOLVE trial, patients who had calcium to normalize their PTH, they did not have better cardiovascular outcomes. Similarly, in some of the statin trials, like the Aurora trials, patients on dialysis had no cardiovascular benefit when they were treated with fluvastatin compared with placebo. So I think that in summary, in the CKD population, normal may be different from the non-CKD population, and we should mostly talk about target hemoglobin, which may be lower than the normal hemoglobin in the non-CKD population. And I think it will be really hard based on the trials we have so far to prove that normalizing hemoglobin is a good thing for these patients.
Thanks very much. And we'll hear from Evi now and then have a brief discussion.
Okay, well, I approached this question from a slightly different angle. For me, the question is, why should normalizing hemoglobin ever be an aim? In medicine, we tend to see an abnormality, we link it to bad outcomes. We tend to believe that by reversing the abnormality, the bad outcomes will automatically improve. And anemia has been a prime example of why that assumption does not necessarily hold. Now, we've blamed ESA as a compound, we've blamed the dosage, we've looked for different compounds, but the question really is whether symptoms of anemia and the long-term outcomes that are possibly linked to the anemia improve when anemia improves. And of course, our older colleagues will remember those pre-ESA, pre-iron times when people looked and felt absolutely dreadful due to severe anemia. And clearly there is a point at which anemia causes symptoms. The fatigue, the lightheadedness, the shortness of breath, the reduced exercise tolerance and all that. But the question is that reliably and consistently related to a certain hemoglobin threshold? And do symptoms reliably improve as hemoglobin increases on a population level? Or is there a deflection point at which any increment stops translating in symptom improvement? And is that deflection point similar for all, or is there inter-individual variability in when symptoms appear and disappear, which doesn't just seem far more likely, it's what we see in practice too. And the problem when you start thinking about hemoglobin targets, especially within clinical guidelines, because that's essentially what the question is about, obviously, is that we tend in clinical guidelines, we tend to stick to randomized controlled trial data. But the problem is that that kind of data does not teach us any of the above questions. And that's for two major reasons. Because one, the effects on health-related quality of life, on fatigue, are not particularly well studied. There are few randomized trials that have looked at outcomes like fatigue or health-related quality of life. And those that do, they are mostly at high risk of bias due to lack of blinding. And there are considerable concerns around publication bias and so on. And so that becomes a problem. And then the second issue is related to the fact that classic randomized trials are discrete comparisons between 2 or 3 treatments. And so any treatment effects essentially rides on the choice of your hemoglobin target in both the intervention and the control groups. It's a discrete comparison, and so it cannot indicate the deflection point at which an incremental rise ceases to translate into symptom improvement. And I think that is the challenge. We don't have those data, and with the idea of personalized medicine in mind, I think we should aim for having both randomized trials, but also observational data that can help us make those informed decisions. There are ways of doing that. I think you can have, especially in dialysis populations, you can have sequential randomized controlled trials where you repeatedly randomize the same patient to a different target, hemoglobin target, and look at differential effects of those. And that's obviously the more challenging, but possibly also the more informative one. You can also use observational data and proper causal methodology that looks at dynamic treatment strategies to kind of inform deflection points, individualized deflection points based on a variability or variety of clinical characteristics of those patients. So that would be my answer.
Thank you. That was great. And I think on a very simplistic level, in my clinical practice, I approach the threshold for starting treatment, the target I want to achieve, very differently in different people. If I've got a 20-year-old who works on a building site, who's starting to get symptomatic and it's impacting on his quality of life, I may start treatment at a higher hemoglobin threshold than the guidelines might suggest. And I might be happy in someone whose CKD is driven by a single organ GN or something like that, where there's no other cardiovascular risk in a young person, to let the hemoglobin go above the target from a guideline, because I'm individualizing that and I'm getting immediate feedback for that individual on improving his quality of life, because that's what matters. Whereas in someone who's perhaps a lot older, more sedentary, who isn't needing that higher hemoglobin to maintain their quality of life and activity, I'm doing exactly the same, but at different targets, which is exactly what you were talking about, Evi. And we do that without thinking about it in clinical practice, don't we? And we take the patient as they walk into the consulting room and we think about them in their entirety and what's important to them, and we tailor the treatments, which of course is not how a randomized controlled clinical trial works. So I really like what you've both come up with, is what is normal. And that normal is different depending on whether you're on dialysis, whether you've got CKD 4, 5, 3, whether you're 80 or whether you're 20, and what you're up to and what you're doing. And we don't have any information about those subtleties in the data available at the moment, do we? So I think it's really interesting that we need to think about what is right for that person. So how would you approach that from a guideline perspective? Because that needs a guideline in its own right, just in terms of that personalization.
Yeah, I think that's the biggest challenge. Obviously, there's a tension to a desire to wanting to stick to the controllable evidence that's there, which limits us mostly to randomized controlled trial data, because there's a desire to have the unbiased estimates of effects. But then because there's aggregation of patient characteristics and heterogeneity within the patient groups that are included, you lose the granularity in the differential effect. And so I think what I foresee in future, that will not be part of the guideline at this point in time. And I'm expecting that will come up in practice points rather than in actual recommendations which are directly linked to the underlying evidence that we look at. But what I expect in future to happen is that we may gradually want to rely on observational data that are underpinned by very good causal methodology. I think there's a dearth of the promise of incredible amounts of data that can be reliably used to inform these kinds of decisions. But the trick there will be to emphasize the necessity of high standard, state-of-the-art causal methodology. And if you apply that to observational data, then I think we might be that indicating or elucidating these individual targets that may be within our reach just even by using observational data that we gather in our everyday practice. How to formalize that into a guideline development process is going to be a different matter, because at this point in time, I believe that the mastery of those causal methods lie within the hands of a couple of data analysts around the globe, but it's not it hasn't trickled through to the medical community well enough yet at this point to be easily introduced into guideline development methodology. And so that's going to be the challenge.
Thanks. And I'm taking it the other extreme, Sokratis. If we thought about it on an individual patient basis, I really was very interested. So would we ever get to the point where we might say we're correcting anemia to make the patient feel better? We've got no evidence that actually minor changes are going to impact on hard outcomes, cardiovascular outcomes, for instance, rate of loss of GFR, all those aspirational things we hoped correcting anemia might convincingly show us. Do you think there's a point in which we might say we're going to titrate your treatment to achieve a hemoglobin where your symptoms have peaked, i.e. you're less fatigued, but we're going to think about not raising the EPO dose, no matter what your hemoglobin is, if you've actually got your exercise tolerance back to where it should be? Do we think we could titrate that using some form of life participation questionnaire to say, okay, because it's quite interesting, we might get them to a certain point and we can't get them any better than that, even though we can put the hemoglobin up 2 grams with more drug. But why are we doing that if we've already reached the clinical effect that patient is telling us? What do you think about that? Do you think that's possible? Do you think that's sensible, or is it mad?
Yeah, I think that's absolutely sensible. So based on the symptoms, so we get at the level of hemoglobin that we think is appropriate for the patients, and if the symptoms have resolved, the anemia symptoms have resolved, then that's plausible. We can stay there and we shouldn't push any further. Though with regards to fatigue, that's a major issue, especially in patients with CKD. Fatigue is a very non-specific symptoms. One of the non-specific symptoms you can't really judge based on the fatigue. So it's one, to my experience, is probably the most commonly mentioned symptoms when they come in the clinics, and it's difficult to pinpoint. And recently, I have found out that most of the patients that they say I'm tired, they're not actually tired, they're sleep deprived. So they have poor sleep pattern, they don't sleep well, and then they say they are tired. But in general, fatigue and tiredness is multifactorial. It's very difficult to pinpoint if this is only based on the hemoglobin, the reduction in the kidney function, cardiovascular disease on the background, diabetes, and most of the times it's poorly controlled. So there's so many different factors that I would say it's very, very difficult to judge based on the fatigue or kind of quality of life symptoms as many factors contributing there.
Yeah, and I think we need to manage expectations. So I think if we were to use that, we'd have to accept we may only get a 20% improvement and not a complete resolution. But once we've seen the increment from a treatment of anemia, we don't want to keep battering the hemoglobin higher and higher and because as you say, that's not what's causing the fatigue. There are other things here. So we're essentially over-treating because it's the one thing we can do that's relatively easy, isn't it? Whereas all the other things are a bit more complex. So yeah, I think I'm quite interested, and I think we do need to operationalize how we do this from a guideline perspective with what Evi has mentioned. But in terms of practice, it's often something that experienced clinicians will do is they'll realize they're not going to go after a hemoglobin target when they're not seeing any improvement in front of them. And it's how we think about that. And the new agents clearly haven't given us that opportunity because the cardiovascular effects do not seem any different. And so we're still hamstrung, aren't we? So I'm conscious of time. And actually, we could have only had 2 questions because I think we could have the time. But so I think in terms of the audience, a very quick response from the both of you about where you think the next innovative treatment target is going to be, or where should we be looking? So Evi, over to you. It doesn't have to be long. Is there an obvious one? There may not be an obvious one that you think.
I'll leave that answer to Sokratis. Again, my background is very much in guideline development methodology, and so the basic science and the pathophysiological aspects of development of anemia and CKD is not particularly my realm. So, Sokratis, please.
Yeah.
Yes, again, I have prepared a slide which is not very relevant, but just to show you. So first of all, yes, I'll try to be very quick. So this is the evolution of treatment of anemia. This is a graph showing how long it took us to go from the discovery of the EPO back in 1950s to purification and cloning of EPO in the 1970s. It took us essentially up to half a century to get that out there and using that in clinical trials and maybe longer to use that for in clinical practice. And then the same for the HIF-PH inhibitors. They were first discovered in 1996, and then it took up until 2016, until the role in the hypoxia, the role of the HIF pathway in the hypoxia, censoring of hypoxia, and how the pathway works, became kind of was discovered, and that led, as you know, in the Nobel Prize down in 2019, and the 3 doctors involved with that. So it took us approximately half a century for both agents to develop, and this tells us how difficult it is to get these agents out in the market. With regards to new agents, there are ongoing kind of trials with hepcidin inhibitors, direct hepcidin inhibitors at the moment. At a very preliminary kind of stages. There are new agents targeting pro-inflammatory cytokines like IL-1 and IL-6. There are new iron agents like ferric citrate or ferric maltose. But I think there is a new agent which is out there and we have not paid so much attention, and it's the SGLT2 inhibitors. There is growing evidence suggesting that they have an effect in hemoglobin, which has nothing to do with hemoconcentration, has nothing to do with volume depletion. They have been shown to increase endogenous EPO production by 30%, and this is associated with increase in reticulocytes, decrease in ferritin. So this all is in keeping with better iron utilization and proper erythropoiesis. So SGLT2 inhibitors is probably another one to consider for anemia as well, apart from the other indications.
So I'm going to be a bit cheeky here and ask, do you think the guideline committees would want to put SGLT2 inhibitors in the water for everyone, bearing in mind they seem to be able to sort a whole range of different problems? But I think you're right. I think it's going to take a long time to get new therapies through that testing process. And we probably don't quite know how well to use the existing therapies. And, the SGLT2 inhibitors may be beneficial. We'll see in terms of the data real world. But I guess SGLT2 inhibitors, you don't need to say if you don't want to, but Evi, have they featured in the anemia guidelines? Is it an observation that is just an observation at the moment and not thought of as a proactive way of managing anemia of CKD?
It definitely doesn't feature in the guideline. There's been no active search regarding evidence supporting the use of SGLT2 in anemia treatment. So it won't feature in the current update. For a personal perspective on that is that I'm always fairly cautious when certain effects seem to appear within clinical trials and beyond that do not fit clearly with its mechanism of action, that is seen as sort of a random but not necessarily a random, but an observation that is picked up within trials and uncontrolled studies, and doesn't have bioplausibility behind that. You need to be very careful that you're not picking up on noise here, and that you don't jump to preliminary conclusions as to their true effectiveness, especially if you're going to use that as an aim to increase hemoglobin, because then at that point you're treating for a different purpose, and so your side effect profile and your harm profile will shift as well. So yeah, that would be my cautious preliminary note.
Watch this space. I think we need to think about it, and it's great to have raised that as something we need to go away and think about. And so finally, we've only got a few minutes left. So this next question is something I get asked all the time, because clearly it's really important for the patient in front of you. And it's something that we do see a lot of in nephrology. So how do you approach the treatment of patients with anemia of CKD who have a malignancy, not specific to any particular treatment? And I'll come to Evi first, because that is presumably something that it may be a practice point because there isn't the volume of data needed to make a recommendation. But really, there's a challenge here, isn't there? How do you generate the data? Are we going to be waiting another 10, 15 years before we know the answer, and it's going to have to go on expert opinion? How do you include that in a guideline, and what would you be looking for?
I think the simple answer to that would be not having it in the guideline, and that's essentially where we'll likely land. Because from a methodological perspective, any attempt to answer such questions should have an active search for evidence behind that. And to keep the guideline within scope, usually an attempt is made to focus questions on where the evidence lies, to avoid coming up with 250 pages of practice points, which then essentially ride on expert opinion anyway. I think the question of anemia of CKD, or anemia and CKD and malignancy, is a very vexing one. And at this point, again, I think the data is very poor in that respect. There's a question about how to define CKD, anemia of CKD in such a population. There's the question of differentiating, and that becomes a diagnostic question more than it is a therapeutic question, but how to differentiate anemia of CKD from malignancy associated anemia from chemotherapy associated anemia. So it's a big challenge to differentiate the three. And obviously, when formulating recommendations in these particular patient groups, the ability to formulate a recommendation essentially rests on your ability to differentiate the three situations. And I think at this point in time, we have big problems in doing that. We don't really know very well how to differentiate these three situations, and hence, because they likely have different benefit-harm balance when treating with iron and when treating with ESA, I think it's very it remains a very complicated issue to answer at this point. I think if you can manage to do that, to differentiate these three different situations fairly reliably, then again, getting that information will ride on having good observational studies that reliably allow you to make that association, rather than expecting any randomized control being able to show how to proceed in this area.
Thanks. And Sokratis, just to finish off, I mean, from a practical point of view, we've heard how challenging it's going to be to get an international guideline on this question. What's your view on clinical practice in terms of how you handle this situation?
Yeah, I think there is a fine balance between three different risks here. The first risk is what is going to happen if we don't treat the anemia in these patients, or what is going to happen if instead of using ESA or HAF inhibitors for anemia, we carry on with blood transfusions. The second risk is the risk of thromboembolism when we're using the ESA, which I think is the most important risk to consider. And the third part is the risk of tumor progression. Again, I'm going to quickly show you my last slide on this one. And on the left-hand side, this is a meta-analysis of patients with cancer treated with ESAs for chemotherapy-related anemia. It's a huge amount of patients, 15,000 patients. The mortality risk was not higher in patients treated with ESA versus the ones not. Disease progression, again, there was no signal there, but there was a 50% high risk of venous thromboembolism. And at the bottom side, it's a summary of meta-analysis with similar endpoints. They haven't also shown a signal with regards to disease progression by using ESAs in patients with chemotherapy-related anemia. I think the important here is the targets again of the hemoglobin. I think there was a previous using the CKD targets of hemoglobin up to 11, 12 with high EPO doses. I think we should be more confident that this is not going to pose any risk with regards to tumor progression. However, the risk of thromboembolism is always there. So it's definitely a balance between all the three factors that I've mentioned at the beginning.
Thank you. And we're conscious of the end, and I will just finalize the conversation by saying, just as we've spoken, it's about individualizing that approach to the patient in front of you. Guidelines are great, but they are guidelines. They're not a protocol about how you should treat every patient. They are there to give you the context and the data that's available and to have interpreted them, but you must individualize your approach to the patient. And an approach to a 35-year-old lady with breast cancer that's potentially curative would be different to a person with multiple myeloma in their 80s, where there's a very different risk to benefit profile. So I think this does come down to individualizing your approach and the pros and cons of your options, of course, discussing with the patient, but again, it's about individualization. And I saw Evi nodding, and I'm glad she did, but as a guideline guru, but the guidelines are guidelines, and we need to individualize and personalize the approach. And the one final thing I say for the young trainees on the call is it doesn't always have to rest on your shoulders. Seek advice and guidance from colleagues, particularly for these contentious and difficult situations. Because there is not the data out there, as we've kind of highlighted, to give you a definitive answer on these. So I'm going to finish and let my colleagues come with a final comment on what we've discussed today. So Evi, anything you'd like to just finish up with and comment?
I think it's been an interesting discussion. I think what it highlights is that for me, we've made important progress in moving away from wanting to normalize hemoglobin to individualizing targets. And that holds not just for EPO or iron treatments, it just holds for treating anemia in its entirety. And I think that's a great shift in thinking that we've gone through.
Thank you. And Sokratis.
Yes, within the same line. So what is normal for non-CKD patients may not be normal for CKD patients, as shown in many trials. Definitely difficult decisions. We need to individualize. And with regards to the new agents compared to the older ones, yes, they're not superior, but at the same time, there is a role for them, and we should just throw them out of the window because they have not showed any superiority in the trials.
So thank you. It's been a fantastic discussion. I've really enjoyed talking to you both.